Let's talk about the adrenal glands. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to look at a few adrenal gland disorders. It's not going to be an exhaustive lecture, so these are just the important clinical ones that you really need to know for the sake of your exams and the ones that we see commonly on the wards. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend that we're back doing regular content on the channel, and let's go. Here's a warm-up question. In a patient with central fetal obesity, acne, hirsutism, the most likely diagnosis is A. Cushing syndrome, B. diabetes mellitus, C. hypogonadism, D. hypothyroidism. So you may pause the video if you may, write down your answer. I will give you the answer at the end of the lecture. So let's get into first a little bit about the anatomy of the adrenal glands. Remember that the adrenal glands are going to be found on top of the kidneys. Just like I showed you in the very first image of this lecture, the adrenal glands are like a hat that is on top of the kidneys. So they are also referred to as the suprarenal glands. They are divided into two parts, predominantly an adrenal cortex and an adrenal medulla. The adrenal medulla is found on the inside, the adrenal cortex is found on the outside. The cortex is divided into three histological layers. So these layers are as follows: the zona glomerulosa, the zona fasciculata, and the zona reticularis. So the zona glomerulosa produces mineralocorticoids such as aldosterone. The zona fasciculata produces glucocorticoids such as cortisol. The zona reticularis produces androgens, which are the sex hormones. So there is a mnemonic that you can remember. Just remember GFR. GFR. G for zona glomerulosa, F for zona fasciculata, R for zona reticularis. And you can remember GFR from the glomerular filtration rate. It will help you remember that they're on top of the kidneys. Then also remember that it gets sweeter as you go deeper. So salt for the zona glomerulosa, sugar for the fasciculata, and 6 for the reticularis. Then you have the zona medulla. Actually, the adrenal medulla, not zona medulla, I don't know what I'm thinking about. The adrenal medulla, which is going to be consisting of these special types of cells, which are known as chromaffin cells. And these are actually going to be derived from the embryonic ectodermal neural crest. And these are responsible for the production of the catecholamines, predominantly your epinephrine and norepinephrine. So here's a histological picture of how they look like. So here we have aldosterone that's secreted from the zona glomerulosa. We have the cortisol, which is predominantly from the zona fasciculata. Then, of course, the androgens, which are pretty much from the zona reticularis. Then, of course, in the adrenal medulla, you have these chromaffin cells, which produce epinephrine and norepinephrine. The adrenal glands are found on top of the kidneys. Now remember that these hormones are very important for special things in the body, so keep that in mind. Then there are some common diseases that we often see that are affecting the adrenal cortex and those that are affecting the adrenal medulla. We'll start with the ones that affect the cortex. So you could have two predominant problems here. You could have either they are not producing the hormones that they are not that's supposed to be producing. You call this as a problem resulting from inadequate production. An example is Addison's disease, where there's inadequate production of cortisol and aldosterone. Then you can also have, on the other end of the spectrum, diseases that cause excessive production of hormones. One example is Cushing syndrome, where the excessive cortisol production. You may also have primary hyperaldosteronism, where there is excess production of aldosterone. Then in the adrenal medulla, we'll pretty much talk about the Pheochromocytoma, which is a tumor that secretes catecholamines. It's a tumor of the adrenal medullas. So we'll begin with Cushing syndrome. So when you talk about Cushing syndrome, this is just pretty much a clinical syndrome that's going to be characterized by excessive production of cortisol or other glucocorticoid hormones in the circulation. Now, there is a large spectrum of the disease and the clinical manifestations. Some people may not have any symptoms, while others may have overt symptoms depending on certain things, such as the duration, as well as the intensity of the the production of the steroid hormones. Then this occurs mostly following therapeutic administration of the synthetic corticosteroids, or ACTH, adrenocorticotrophic hormone. Because remember that the endocrine system is under the influence of the master endocrine gland, which is known as the pituitary gland. So in the pituitary gland, there is a hormone that is produced, which is known as adrenocorticotrophic hormone, which is produced from the corticotrophs. Now, this is what stimulates the adrenal gland to produce its hormones. So in this case, you may have, for example, a tumor that is present inside the pituitary gland that is producing a lot of ACTH, such that it will stimulate the adrenal glands to produce a lot of cortisol. Sometimes you may have spontaneous Cushing syndrome, which is quite rare. Now, if the ACTH is actually coming from the pituitary gland, we refer to that as Cushing's disease. If it's coming from elsewhere, it's referred to as a Cushing's syndrome. Now, what are some of the causes? One major cause is iatrogenic, which is, of course, exogenous administration of corticosteroids. This is actually the most common cause, and it's actually rarely reported in most of the cases. So, for example, patients that are on long-term glucocorticoid treatment, like patients that are with asthma, patients with arthritis, and even other conditions. Then, of course, remember that in this case, you're giving this person the corticosteroids. Remember that the body does not keep producing what it doesn't need. So if you are producing this corticosteroids, or you are giving these corticosteroids, the adrenal glands will no longer be producing the corticosteroids, such that they become atrophic. So both adrenal glands become atrophic in this case, because there'll be a decrease in the production of ACTH, there'll be a suppression of the exogenous, or rather suppression of the endogenous production of cortisol. Then you may sometimes have ectopic ACTH syndromes, where you have a tumor that's producing ACTH. That's in the so-called paraneoplastic syndromes. It's very, very common, especially among the small cell lung carcinomas. And this is actually the second most common cause of Cushing's syndrome, but it's often misdiagnosed or not really even diagnosed. So here, both the adrenal glands are enlarged because the ACTH, instead of it coming from the pituitary gland, it's coming from this small cell lung carcinoma, which is stimulating it to produce cortisol. So both adrenal glands become enlarged. Then you have Cushing's disease, which is pretty much coming from the pituitary tumor, which is producing the ACTH. So this is from the pituitary causes. So it is 5 to 6 times more common than Cushing syndrome, and it's caused by both benign and malignant tumors. Then in this case as well, because the ACTH is stimulating both adrenals to produce these hormones, both adrenals become enlarged. Then you may sometimes have tumors that are present inside the adrenal glands. You may have adrenal tumors, you may have hyperplasia, or even carcinomas that may be present. So these ones usually are detected on autopsy and sometimes incidentally on radiological investigations, and they are going to be accounting for 1.3 to 8.7% in adults, and of which 99% of them do not have any symptoms. That's why it's an incidental finding. So here, the affected gland is going to be large because it's going to be having this tumor that is growing in it, whilst the normal adrenal gland is going to be atrophic because it will be suppressed by the ACTH. Remember that tumors do not respond to the normal signals of the body. So even if you have a lot of ACTH being produced, the adrenal gland that has the tumor will not respond, but then the one that is normal will respond, and it will decrease, it will become atrophic because it won't be producing as much of the adrenocortical hormones as compared to the other one that has the tumor and is not responsive to the ACTH. So you can divide the causes as in ACTH dependent causes, those that depend on ACTH and those that do not depend on ACTH. So the ones that depend on ACTH include the pituitary adenomas, pituitary tumors, that's the Cushing's disease. Then it could be ectopic secretion of ACTH tumors, for example, in the small cell lung carcinoma, or it could be exogenous administration of ACTH. Then you have the ones that don't depend on ACTH, for example, adrenal adenomas and carcinomas, glucocorticoid administration, even alcohol-induced pseudo-Cushing's syndrome. What are some of the clinical features that we often see? So this patient is going to be having progressive obesity, and this obesity is quite characteristic because it's in the central area. So they'll have this central obesity, they'll have wasting of the extremities because the muscles are going to be broken down by gluconeogenesis. Remember here, the underlying thing that says that you have a lot of cortisol. Remember what cortisol is going to do. It works in a quite similar way to glucagon. So it's going to be stimulating the breakdown of the glycogen into glucose. It will stimulate the breakdown of proteins. It will stimulate the synthesis of glucose from non-carbohydrate precursors, which is pretty much the process of gluconeogenesis. So muscles are going to be broken down to facilitate gluconeogenesis. So this person tends to have muscle wasting, such that they won't even be able to climb up a flight of stairs. Sometimes they may even be too weak to stand. Then because you have a lot of ACTH that is present in these patients. ACTH actually stimulates the melanocytes and actually can cause pigmentation of the skin. It may cause purple striae with skin atrophy as well as easy bruising. They may have this cushingoid appearance where they have a moon face. They may have a buffalo hump. We no longer refer to it as that. We call it as an interscapular fat pad or cervical fat pad. They may also have a supraclavicular fat pad. They do often have impaired glucose tolerance and sometimes even frank diabetes. And this is especially very common in the ectopic ACTH syndrome. They may have other things like hypokalemia, because remember that this mineralocorticoid activity that cortisol has will stimulate the reabsorption of sodium, and this will be at the expense of potassium. So they tend to have hypokalemia. Because you're retaining more sodium, you are retaining much more water, there's a higher chance of hypertension actually occurring in these patients, and it's actually common in all patients with Cushing's. And this actually results from the vascular effects of cortisol. It also tends to upregulate the alpha-1 receptors on the arterioles. It also causes sodium retention, as I already alluded to much earlier on. You may also have menstrual irregularities, oligomenorrhea, hirsutism, acne. This is due to excess androgens that are stimulated by the ACTH. You may have a decreased glucose tolerance, which is because of the hepatic gluconeogenesis and the decrease in the peripheral glucose utilization. You may have osteoporosis because the body is in a catabolic state. You may have poor wound healing, which is as a result of the poor immune function. Remember, corticosteroids are immunosuppressive. Then you may have growth retardation. You may have psychiatric disturbances, especially depression, which is frequently seen. And the most common feature of patients that actually do have Cushing's syndrome is the progressive central or truncal obesity, which is usually involving the face. They have this roundish moon face, and the neck, the trunk, and the abdomen. Then the limbs, the proximal extremities will actually be spared, so they may even be wasted. So the moon face, the buffalo hump or the cervical fat pad, and the supraclavicular fat pad contribute to what is known as the cushingoid appearance, which is as a result of excess insulin being produced because of high levels of glucose, and this excess insulin results in the storage of fat and synthesis of adipocytes. Then you may have some dermatological features such as skin atrophy. The skin actually becomes quite thin. They lose their subcutaneous fat to a sufficient degree such that you can actually see the subcutaneous vessels. If you actually have seen someone who has bleached the skin because they use a lot of corticosteroids, that's probably how a Cushing's patient would actually look like. So the stratum corneum is actually thinned. They may easily bruise because they lose their subcutaneous connective tissue due to this catabolic effect of the glucocorticoids, and they may also have this purple striae, and this purple striae are often over the enlarged trunk. They may be seen over the breast, they may be seen over the abdomen, and the striae are going to be appearing as this wide reddish purple streaks, and they are very common on the abdomen and the lower flanks. Remember that cortisol actually impairs the synthesis of collagen, so the blood vessels are weak and they easily rupture, forming this striae, so we call them as ruptured blood vessels. There is also a risk of fungal infections. Remember that corticosteroids are immunosuppressive, so the cutaneous fungal infections may be seen, especially tinea vesicola, while other patients may have fungal infections of the nails. You may also have hyperpigmentation, as I alluded to. Remember that ACTH has a very similar structure to melanocyte stimulating hormone. You may also have the hirsutism because of the excess production of androgens as well, because of under the influence of ACTH. You may have menstrual irregularities, oligomenorrhea, amenorrhea, sometimes even excess or variable menses. Then you do also have proximal muscle wasting and weakness. Remember that these are very common. The body is put in a catabolic state because of the excessive glucocorticoids that are being released and their effect on skeletal muscles. Remember that many patients actually are not going to be able to rise up from a squatting position because they do not have those muscles that enable them. The muscles are atrophied and they're weak. So they're unable to even climb up a flight of stairs. They're unable to get up from a deep seated chair. Then they may have also the catabolic effects of cortisol being amplified by physical inactivity. Remember that cortisol is one of the stress hormones. Then hypokalemia can also be seen in these patients, and this can actually contribute to the muscle weakness. Remember, the hypokalemia is as a result of the expense of the mineralocorticoids that are produced that cause retention of sodium at the expense of potassium. You may also have bone loss. Osteoporosis is a very common thing among Cushing's syndrome patients, and we find that the vast majority of patients are actually female. And They are probably postmenopausal. It is caused by a decrease in intestinal calcium absorption, as well as a decrease in bone formation, an increase in the bone resorption, and a decrease in renal calcium resorption. And this actually can be demonstrated by a densitometry of the lumbar vertebra. Even in younger patients, you see that the density of the bones has actually significantly reduced. Pathological fractures are often the result of this bone loss. You may have some neurological features, psychiatric conditions that are very common in Cushing's syndrome. Things like emotional lability, agitated depression, irritability, anxiety, panic attacks, and even mild paranoia. Infections and even the immune system is often suppressed. This is because glucocorticoids inhibit the immune function. So they do contribute to increasing the frequency of infections in these patients. One mechanism that has been postulated is the ESA4 in the CD4 cells, and there's even a decline in the natural killer cell activity. Remember that another mechanism is that the cortisol itself inhibits the phospholipase A2 enzyme. And remember that this enzyme is very important to break down phospholipids into arachidonic acid, which can enter one of two pathways, the cyclooxygenase pathway and the lipoxygenase pathway, which are responsible for production of chemical mediators of inflammation. So once this has been inhibited, this actually does affect the immune function. And then, of course, the major effect is that the glucocorticoids also inhibit the synthesis of almost all the cytokines. And remember that cytokines are actually quite key to mounting an inflammatory response. So here is a summary and a picture of all the different clinical features that we have actually talked about. Here's a cushingoid appearance of the face. As you can see, it's round and it's like a moon face. This woman here is truncal obesity with proximal wasting of the muscles, very thin arms, very thin legs. They have hypertension. They may have a fat pad, which we do not call a buffalo hump anymore. They may have a moon face. They may have emotional changes. They may have a thin skin. They may have purple or reddish abdominal striae, pendulous abdomen. And here's a list of all the other clinical features, and here are the abdominal striae over there. So you can pause the video at this moment, take a screenshot of this, and it will help you remember the clinical features of Cushing's syndrome. So how do you make a diagnosis? So there are two phases of the diagnosis. There's the confirmation as well as the differential diagnosis of the cause. So to confirm, what can we do? So we can do what is known as a 48-hour low-dose dexamethasone test. So remember that under normal circumstances, individuals are supposed to suppress the plasma cortisol level to less than 50 nanograms per liter. So 50 nanomoles rather, not nanograms, 50 nanomoles per liter. So in patients that actually have Cushing syndrome, they won't be able to suppress the plasma levels of the cortisol, although the levels may fall substantially in some selected cases, but they're not able to suppress. So you give this dexamethasone overnight. So this sometimes is less sensitive and has a higher false positive rates, but in some cases it does have a high sensitivity. When you talk about the 48-hour low dose dexamethasone, where we're giving them low dose at specific intervals over 48 hours, then you keep monitoring the levels of cortisol. The thinking is this: if you give someone the exogenous corticosteroids, you expect the body to not produce the corticosteroids. If they are producing the corticosteroids, then it means that there is a problem somewhere else. So if the suppression is not less than 50 nanomoles per liter, there is some problem elsewhere in the body. Then you may have a 24-hour urine free cortisol measurement. So this is actually simple, but it's not really reliable. So you need to repeat the normal values. And if you get a normal value, it may not really rule out the diagnosis. And once you get normal values repetitively, then in some patients actually the diagnosis becomes unlikely. And some patients of Cushing syndrome actually have normal values on the collection. About 10% of them can have normal values of urinary free cortisol levels. Then, of course, the circadian rhythm. So after 48 hours that you admit this patient in the hospital, you can take the cortisol samples at 9 hours, and then after that at 24 hours without warning the patient, because once you warn the patient, they'll be stressed about it and cortisol gets released. So under normal circumstances, the person is supposed to produce this circadian variation, and those that have Cushing syndrome, they will have this high midnight cortisol levels greater than 100 nanomoles per liter, though the 9-hour value may be normal, but the midnight one tends to be elevated. Then midnight salivary cortisol can be collected at home, and it actually gives similar information. And in some places we actually do this, but in our current setup we don't have the facilities to do this. Then the other investigations are pretty much aimed at now finding the cause of the Cushing syndrome, because a cause must be identified. So those that have severe hirsutism and virilization, this may suggest an adrenal tumor. You may order for certain radiological tests such as adrenal CTs and MRIs, which can pick up the adrenal adenomas and carcinomas that are causing Cushing syndrome, and these often tend to be large and can be detected by CT scan. You can get a pituitary MRI that may rule out a pituitary adenoma, and sometimes this tend to be quite small in the pituitary gland, and they're actually sometimes not visible in most of the cases. A chest x-ray to rule out carcinoma of the bronchi. Then you may also do some biochemical tests. So potassium levels, remember that hypokalemia is very common, especially with ectopic ACTH secretion, so all diuretics should be stopped. Plasma ACTH levels can be done. They tend to be low or undetectable on 2 or more occasions, and this is actually a reliable indicator of non-ACTH dependent causes. You may also have a CRH test, so an exaggerated ACTH production or cortisol response to exogenous administration of corticotrophin releasing hormone actually is going to be suggesting that this is a pituitary problem. Then you may do a high dose dexamethasone test, so failure of significant plasma cortisol suppression is going to be suggesting that there is an ectopic ACTH being produced, or there is an adrenal tumor. Remember that once you give the dexamethasone, the ACTH is supposed to reduce due to that negative feedback that is seen in a normal individual. So how do we treat this patient? So untreated Cushing syndrome actually has a very bad prognosis. Patients actually die from hypertension, they may die from myocardial infarction, they may die from infections, and even heart failure. Whatever the underlying cause that is there, we should correct that. So correct the underlying cause, and correct this prior to any surgery, prior to any radiotherapy, because if you do not correct this and you give this person surgery or radiotherapy, all those hormones gets spilled into the bloodstream, and this becomes a danger to the patient. So we treat the Cushing's disease. So we can remove the tumor. If it's a tumor, that's a treatment of choice, a transphenoidal removal of the tumor. We can do external pituitary radiation. Medical therapy can be given to reduce ACTH using bromocriptine. Bilateral adrenalectomy can be done. And then we treat the underlying cause. If it's an adrenal tumor, like I said, we resect it. If it's a tumor secreting ACTH, it should be removed surgically. Otherwise, chemotherapy or radiotherapy can actually be used. Now, before I actually move on from Cushing syndrome, I want to talk about 2 things. I want to talk about Nelson's syndrome, and I also want to talk about pseudo-Cushing syndrome. So when you talk about Nelson's syndrome, there's just pretty much an increased pigmentation because of high levels of ACTH. Remember, ACTH has a similar structure to melanocyte-stimulating hormone, and this is often associated with an enlarging pituitary tumor, which occurs in about 20% of the cases after a bilateral adrenalectomy for Cushing's syndrome. Remember that once you remove both adrenal glands, ACTH is no longer going to be suppressed because you don't have the feedback mechanism, the negative feedback mechanism, such that now you're going to be producing a lot of the ACTH hormone, and this is actually going to increase the pigmentation. So the syndrome actually now is rare because adrenalectomy is a very uncommon primary treatment measure that we use, and of course the incidence may be reduced by pituitary radiotherapy after you do the adrenalectomy. Then in patients that actually do have chronic alcoholism and in patients with depression, there is actually an increased urinary excretion of steroids, and they do not have that diurnal or circadian variation of the plasma steroids, and they may sometimes have a positive overnight dexamethasone test. This is what we refer to as the pseudo-Cushing's syndrome. Now we move on to hyperaldosteronism. So remember that the distal convoluted tubule has 2 types of cells that respond quite differently to aldosterone. So they have the principal cells and they have the alpha intercalated cells. The principal cells are pretty much going to be responsible for reabsorption of sodium and secretion of potassium. So when in the presence of aldosterone, these are the things that aldosterone is going to stimulate these cells to do. Then the alpha intercalated cells are going to pretty much increase the excretion of hydrogen ions. So it means that patients that have hyperaldosteronism, for For whatever reason, they have high levels of aldosterone. They're going to present with hyponatremia because you're resorbing a lot of this sodium. They're going to have hypokalemia because you're losing this potassium. You're going to have metabolic alkalosis because you're excreting the hydrogen ions. And of course, you're going to be having hypertension because of the retention of the sodium and the water. So you see these 4 things, then you see that this person may have hyperaldosteronism. So it can be divided into primary and secondary. Primary hyperaldosteronism is the most commonly due to adrenal adenomas. That's a tumor. So sometimes you may have some cases where there's hyperplasia and carcinomas, but these are less common. And here they're going to be having high levels of aldosterone and low levels of renin. So they have an increase in their blood volume. Then you may have secondary hyperaldosteronism, which is due to activation of the renin-angiotensin system. It could be as a result of renal vascular hypertension in patients that have fibromuscular dysplasia of the renal artery or even atherosclerosis of the renal artery. Here there's going to be high levels of aldosterone and high levels of renin. Note the difference between primary hyperaldosteronism, where there is high levels of aldosterone and low levels of renin, compared to secondary hyperaldosteronism, where there is high levels of aldosterone and high levels of renin. Then we move on to the next condition, which is Addison's disease. We're now going to the conditions where there is underproduction. So here this is also referred to as adrenal insufficiency. So in Addison's disease, is actually a destruction of the entire adrenal cortex, meaning there is hypofunctioning of the adrenal cortex. So it's an endocrine disorder that's also referred to as adrenal insufficiency. Remember that the adrenal glands are going to be producing glucocorticoids, mineralocorticoids, and androgens, which are all going to be reduced. This can be divided into predominantly 2 types: acute adrenal insufficiency and chronic adrenal insufficiency, of which chronic in our setting would most likely be attributed to TB. So 90% of the adrenal cortex is actually going to be destroyed for you to refer to it as Addison's disease. So remember this table. You have the zona glomerulosa, zona vasculata, zona reticularis, GFR. Mineralocorticoids, which are pretty much responsible for electrolyte and fluid balance. They increase sodium and water retention. They also are regulated by the renin-angiotensin system. The glucocorticoids are essential for carbohydrate, lipid, and fat metabolism. They increase blood glucose levels and gluconeogenesis. They increase protein breakdown. They also inhibit protein synthesis. Then the 6 hormones are pretty much there's low synthesis in adrenal glands compared to the gonads, but they do also produce some certain sex hormones, especially testosterone in the females. So virilizing hormones actually may be secreted from this area. So when we have acute adrenal insufficiency, this can be in the background of what is known as Waterhouse-Friderichsen syndrome. So this is when someone has a meningococcemia and Neisseria meningitidis infection, a disseminated infection, especially in children. But you may have other causes like Pseudomonas, Pneumococcus, and even Haemophilus influenza. So the pathogenesis is actually quite unclear, but what we think it is that it's due to endotoxins that are actually inducing vascular damage. They're causing massive hemorrhage, which is often associated with disseminated intravascular coagulation and resulting in necrosis of both adrenal glands. So this acute adrenal insufficiency can also be as a result of sudden withdrawal of long-term corticosteroids. Remember, we do not stop corticosteroids abruptly. We taper them off, because if we suddenly withdraw them, this patient can go into acute adrenal insufficiency because the adrenal glands would have atrophied and they are not able to produce the glucocorticoids. So you need to give them a chance to reacclimatize and start producing the hormones as the body needs. Then, of course, stress with underlying chronic adrenal insufficiency. This is where you can have an acute adrenal crisis on limited physiological reserves. Then you have the chronic adrenal insufficiency, which may be further divided into primary adrenal insufficiency, which is obviously your Addison's disease. Then the secondary adrenal insufficiency, where there's a progressive destruction of adrenal glands. In our case, TB is a very common cause where there's caseous necrosis of the adrenal cortex. You may have autoimmune adrenalitis, which is associated with pernicious anemia, thyroiditis, and insulin-dependent diabetes mellitus, AIDS, metastatic disease, especially with lung carcinomas, systemic amyloidosis, fungal infections, hemochromatosis, and sarcoidosis. Clinical features are going to be insidious. So there's going to be this progressive weakness, fatigability, and you may have these non-specific complaints like anorexia, nausea, vomiting, weight loss. Then there may be, if it's primary adrenal disease, there may be hyperpigmentation, which is due to an increase in ACTH, hyperkalemia, hyponatremia, which is the opposite to what we're seeing in Cushing syndrome, hypotension and dehydration. You may have hypoglycemia, sexual dysfunction, and in some cases they may have adrenal crisis where there's an infection, trauma, or surgery, which is going to lead to intractable vomiting, abdominal pain, hypotension, vascular collapse, and eventually death. So in Addison's deficiency, the heart is going to be small. So what investigations can we do? A single measurement of cortisol is actually of very little value, although a random cortisol level that's below 100 nanomoles per liter is quite suggestive, and levels above 550 make the diagnosis unlikely. You may do a short ACTH stimulation test where there's either an absent or impaired response. Then you may do electrolytes and urea, which will classically show you the hyponatremia and hyperkalemia, as well as high levels of urea. Blood glucose may be low with symptomatic hypoglycemia, and of course adrenal antibodies may be present in many cases in the case of autoimmune adrenalitis. How do we manage? We replace the hormones. We address the underlying cause, especially with secondary adrenal insufficiency. If it's due to TB, we treat them for the TB. For the primary adrenal insufficiency, that's the Addison's disease, they actually need long-term replacement with the glucocorticoids and mineralocorticoids. Last but not least is the Pheochromocytoma, which is affecting the adrenal medulla. So this is a tumor of the chromaffin cells. So this is going to present with episodes of hypertension, headaches, palpitations, tachycardia, and sweating. The diagnosis is often going to be made by an increase in metanephrines, an increase in 24-hour urine metanephrine, and vanillin mandelic acid. So the treatment is of course surgical. So before the surgery, the patient is actually given phenoxybenzamine. This is supposed to be benzamine, which is an irreversible blocker of the alpha receptors. This is done to prevent hypertension, because once you remove the adrenal glands, all that epinephrine and no epinephrine will be flushed into the system. I want you to remember the rule of tens when it comes to pheochromocytomas. 10% of them are bilateral, 10% of them are familial, 10% of them are malignant, and 10% of them are found outside the adrenal medulla, very common on the bladder wall. So coming back to our single best answer, which is our warm-up question, in a patient with centripetal obesity, acne, and hirsutism, the most likely diagnosis is A. Cushing syndrome, B. Diabetes mellitus, C. Hypogonadism, D. Hypothyroidism, and the answer is indeed Cushing's syndrome. I really hope you learned quite a lot from these adrenal gland disorders, and this is going to be the stepping stone to your further reading into these adrenal gland disorders. We'll talk about each and every one of those conditions in details much later on the channel. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.